that? Well, because I want to feel like I know what I'm talking about. I want to feel like I'm connected with my clients. And, you know, I understand your struggle, but sometimes feeling like I know too much about a client, I think can get in the way of the exploration of their journey. And so I'm offering the clinicians to do what I have to do, is examine my own narrative and decide what part of my story is showing up in front of this client. What is my need to present in a way where I want to minimize my discomfort? And the truth of the matter is, and I think the panel would agree with me, as clinicians, we need to be seen, or as providers, as the expert. And we don't want to look uncomfortable in front of our clients. We want to appear knowledgeable. And the truth is, it doesn't always happen that way. And so I would say, dealing with the discomfort, give yourself permission to tell the truth. That however familiar you think you are or not, accept it and be okay with it. And invite your clients into that space to collaborate. After all, that in and of itself does build rapport, right? Because the collaboration through the medical and clinical process. Did I answer the question?
Yes, thank you. That was wonderful. Any of our other panelists that would like to chime in terms of how you deal with your own personal discomfort or unknowing and utilize that in regards to the relationship that you build with your patient? Debbie?
I do think to tag into what Jon was saying, I do think so much of it is about us moving towards that discomfort instead of moving away from that. Move into it. You know, if you get afraid of it, it gets bigger and chases you. If you move towards it, it doesn't own you. You get to be a partner with the patient. You know, I think it's collaborative. I don't think there's this hierarchy of the therapist is here and the patient is here and we're all knowing, all seeing. I don't want to be that. I don't want that burden. You know, I want to be an equal partner with my client to help them move towards the place that they want to go, not the place where I think they need to go. And I think that, you know, to not be reductionistic, but I think that really comes down to what we were all taught early on: meet the patient where they are, not where we think they should be.
Yeah, just piggybacking off of that, you know, I think about my own journey and where I came from, and I think it has informed my therapy and my practice tremendously. I grew up in a, oops, that's my dog. Sorry about that. I grew up in a white upper middle class household with lots of privilege, and I grew up in a, you know, not obviously, but at that time a straight household. We had the best lawn on the street, and we took a lot of pride in that. But behind the scenes, you know, my mother was an alcoholic, and these things couldn't be talked about, and we had to keep a certain image. And one of the images was being straight. And so when I came to an understanding of my sexuality with the help of a therapist, tremendous help from her, that opened the door for me to kind of find myself, but it also, I became aware of the tremendous loss of privilege that I was experiencing from a kind of white, straight, upper middle class household to the LGBT. I couldn't hold hands with a partner. I couldn't get married at that time. All these things happened, and that pain of the relief of kind of helping myself figure out who I am, but yet the pain of seeing the loss of privilege and the support that I had with therapy through my life was just essential, and it does inform my practice now. But my journey as a therapist, you have to remember, my journey is not your journey. And so the gift that I think we all try to give is our journey informs us, and I think I'm a more compassionate person, but I need to be curious and understand your journey and be patient, and I don't know your journey. So I need to understand that, as Debbie said, we're kind of partners in the journey, and my job is to help you tell your story and have a safe space.
Great, thank you all for sharing. I mean, I think one of the main things that I heard from this was definitely, you know, utilizing your own discomfort and your own story, but also making sure you create that space that you aren't having that overpower what your patient's story may be, and making sure that you give them that space to truly be able to tell their story. You're not overshadowing that with any of your own discomfort. So it's great to hear that. Now, Ginny, I also wanted to see if you would talk a little bit more, and specifically about some of the unique challenges that individuals from the kind of elderly population, some of our older LGBTQ individuals might be experiencing in regards to their specific mental health needs.
Well, I'm somewhere in the middle in terms of my life. You know, I'm not young anymore. I can't figure out how to get on Zoom meetings, but I am also, you know, not, you know, of the older population, but I do have an AARP card, so that's not entirely true. But I work at a skilled nursing facility and called Broadway House, and our specialty, we specialize in HIV, AIDS, and other infectious diseases. So the population isn't older, but it is not a traditional nursing home older, but it is an older population. And we've had a lot of experience with the, and also some trainings with, and partnerships with other like gay LGBTQ organizations that, you know, give me an increased understanding of the challenges of the older population, LGBT, in terms of their healthcare, mental health. They grew up in a very different time than what we have now. As I said, there was no, you know, you could be arrested for being any part of the LGBTQ community, and Stonewall was only 1969. I was, you know, I was 6 years old at that time, but a lot of our older folks lived pre-Stonewall, and also with the stigma that comes with that, and not just the Stonewall didn't open things up, but it sort of started the ball rolling. But there's you know, there's a lot of our older folks do not have kids. I have 2 kids, and I was at the beginning of the gaby boom, as they say. So you know, a lot of people who get older are living in isolation. They don't have the same sense of safety about sort of sharing their stories. There was danger, and there is danger now. And so if you are in any assisted living, or if you are in even a senior center, or if you're in a nursing home, it is incumbent upon those providers to provide a space and a welcome, some kind of a subtle or not so subtle welcome to the LGBT community, because they're not going to talk to you, and they're not going to tell you, and then they're going to live in isolation. And if they get bullied, they're not going to tell you that, and that's so detrimental to mental health. So we have an obligation to help change that for them.
I just wanted to add a little something. This isn't necessarily about the elderly population, but it's about a word. And I guess it is a little bit about that population. I was 14 in '69 when Stonewall happened, the year before I realized that I was a lesbian at that time. And the word queer, okay, so LGBTQ, we know what the Q stands for. I personally still have a visceral reaction to the word queer, because I saw it used in such a horrible, hateful, nasty, assaultive way, even though that word has been reclaimed and it doesn't mean what it meant when I was growing up. It's in my DNA. I know what it means now. I understand, my brain understands it, but my heart and my soul still has this visceral, almost like a reaction when I hear that word. And so when you were mentioning that, I think that makes us as practitioners ever so beholden to be aware of history and to educate ourselves about history and the basic culture in the language. So I just wanted to throw that in. I know that's just, it struck me when you were saying that.
I think you all are onto something, and I think it's important for me to tell a story, or the story. You know, early on in my career, I would ask myself, why am I exposing myself to so much pain? Why would you choose a profession that seats you at the feet of people's worst experiences? And I have decided that what my responsibility is to those stories is to share them and allow it to impact and influence my practice. What many of us would agree or have already experienced is when we think about the aging population, LGBTQ, many of them have already experienced a living death. Most folks of this population have either and or received an HIV diagnosis or some medical diagnosis. And along with that was a traumatic event. So they also received a mental health diagnosis. And the experience I have had is folks who were diagnosed in the 80s was, well, am I going to live? And that's a real tough question to ask yourself when you're in your early 20s or even late 20s. Like, will I see to live 30? And for a lot of the clients I have treated, they never gave themselves permission to live afterwards. They never gave themselves permission to live. And so now that age, okay, now I see that this impinging end is coming, right? We accept the circle of life, Lion King, right? One of my favorite movies. Now death really is coming. And what people realize is I have guilt because I never gave myself permission to live. And now that I am here, and now that time is running out, if you can think about how that can place a person in crisis, I would refer to that as re-traumatization. And so I share this story with you in hopes that as providers who may provide a service to someone in this population, specifically aging, think about how that story of having two existential crises around whether I will live or die can impact the way in which you provide treatment. Now, my expectation is not that you are the expert of this, but I am asking you to be open. My suggestion, nope, I'm not even able to do that. I'll say to myself then, to remain open to what that experience could feel like, and then to actually have enough energy to make it to my office in front of a therapist and say, help me. I think that would require me to be kind. I think that would require me to be compassionate. I better stop now. All right.
Yes, thank you all, definitely. I mean, as we're hearing, there's some unique challenges that do exist for some of those individuals that might be up in age, especially due to some of that lack of support and things. And I appreciate you all sharing some of your specific experiences with that. We also have had some individuals from the audience even send in some messages talking about some of their specific work and how it's difficult with even a lot of the veterans, and more specifically our trans veterans, especially in regards to that stigma and not really feeling as though the space is really safe for them to be able to identify with that. And then another individual has commented that, you know, they've had some of those same things with some of the elderly population, and it's taken some time for them to deal with that. But then this kind of brings in something that they spoke about in regards to our young patients and them being a bit more comfortable with that sexuality. So I wanted to see if you all could kind of speak to some of the changes that you've seen and the compare and contrast between the elderly individuals versus some of our young individuals.
I think sometimes, and I think I'm open, right? And but now the youth, you're right, Yuvon. There is a new comfort level that is happening. And I would say specifically maybe 18 and under. If I have a client who presents as gay or trans, it's almost like they've had some pre-experience with therapy because they come in with an expectation of I'm ready, I'm open, and we're ready to discuss. And I think not often do I step back and go, oh, you know? And I guess what I am experiencing is their resilience coming forward. You're right, it is a difference. Something is happening among younger LGBTQ+, where the issue is not so much about sexuality. What is happening? I think they're living, and they're allowing themselves to be more than gender, more than sexuality. And so they're giving themselves permission. They're being kind to themselves and allowing them to work on other things in life, like work-life balance, or who do I want to be when I grow up, or what career do I want to go into? So I say all that to say, I think this reflects the resilience of stories and where we are as a society, where gender and sexuality may not be the presenting issue.
I'll add to that. I think that's a great point. I do work with a younger population on the whole, adolescents and younger folks in their 20s and 30s, but a lot of teenagers. I feel like I'm feeling this tornness in my gut between agreeing with what you're saying, Jon, and not agreeing with what you're saying. And I think it's because I see a lot of young folks, exactly what you're saying, being very comfortable with it out in the open amongst their friends where it's more normalized. But I don't think that's what I necessarily see from all of their family members. I'm not saying it's as bad as it was when I was a teenager, but I don't think maybe it's because I have this higher ideal. It's not nearly where I wish it could be for a lot of these young folks, because it may not be the presenting problem that they show up in my office with or your office with, but I think it's often the underlayer. You know, they're oftentimes coming forward with whatever the issues are in their family, and it's going to look like depression because, you know, we all know they get identified as the identified patient, or they are the identified patient with whatever their parent drops them off and thinks that we're going to wave the wand over and fix. And oftentimes it's issues that are bigger than just what it appears to be. And a lot of times it's issues in the family. And I do think that on the whole, a general statement is that young people are more comfortable with it for sure. But I don't think that's always necessarily a translatable thing in their family of origin. I could be wrong, I don't know, but that's just what I see in my practice. And I came from the inner city, and I see kids from all areas.
I saw you really get pulled between 2 points. I saw you moving. I think what's happening is what we don't give ourselves permission to do amongst colleagues, and that is to consult. And I think in this moment, what I'm hearing from you is, Jon, it's okay to look at the whole client. And I think that's, again, a part of my own stuff, right? And maybe focusing on looking at it a certain way. And I think this is the importance when we talk about how to treat or better ways to manage this double stigma. I think it's about having moments like this where you share ideas with trusted colleagues, and they challenge you to think about it a little differently. And you're right, Debbie, it is possible that it may not present as the direct issue, but sometimes it's coded into another layer. And so I think what I'm taking is to be, from this, is to be more patient and be more open, right? That it doesn't have to look and be a certain way. And so for the participants, I hope that allows them to be a little more kind to self and seeing that you don't have to know it all.
We don't need that.
Yeah, if I can jump in, Jon and Debbie, I feel like they covered that topic really well, and I just wanted to bring up a different topic related to teenagers and young adults, which is that I have 2 boys, and they're twin boys, and they're now 20 years old. And one of my boys, I don't think he's watching, but he knows he's a little, has some social awkwardness issues, and he is a STEM kid. And so he started going to therapy, and it really did help him in high school. And then he started college, and he went back this year. And he was talking about a little bit about his experience. That's his privacy, but he shared with me. And he said, Mommy, the therapist asked me about my 2 moms. And I said, well, what did you say? And he said, well, he was wondering if there was a problem or any issues with having 2 moms and growing up as a cisgender male. And I said, well, what'd you say? And he said, well, no, that's not why I came in there for. I came in for other issues. But I thought, now we are having kids more often. And I think as therapists, we may, as parents, we have to be aware of the fact that maybe some therapists are looking and saying, well, wait a minute, just because we're LGBT in the community and we have kids, there's got to be something wrong with that. And so I was, heartened by my son's response, and I wanted to bring that up because we're having kids too now, and they're going to need therapy because it's a good thing to have. Sometimes we screw up, we have issues, and also you know, therapists have maybe a little bit of an agenda. They have to learn too. So I wanted to share that little separate piece.
Yes, and thank you all so much for sharing. I mean, what I'm hearing is that, yes, we do see some differences with this younger population, but there still may be some struggles and some difficulties in regard to what they may be experiencing with their parents and some of the struggles there. Some of our audience members have even stated that there's even some differences they see between like your rural versus urban environments, and that they see a lot of differences in regards to the youth in those situations. And then another one that's bottom, this is actually kind of piggybacking on what you just mentioned as well, Ginny, is kind of being in this sense of, yes, and John, you talked about, you know, we have to create that space where you all as clinicians can go to each other and, you know, admit that you may not know something. But there's also this kind of unwillingness to want it to get to be a situation where your clients are having to teach you about some of these things. So what are some of your thoughts in regards to that? Like not wanting to make it feel as though your clients are having to teach you about these things, or what other resources or other ways that individuals can kind of utilize different resources so that they're not in that type of, my client is teaching me about this situation.
Yeah, I think I got an immediate tap on the hand in graduate school. One of my first rotations out was working with folks in end-of-life transition. And I said, I don't know anything about dying. So naturally, that brought me into a position of being a student to people's experiences. I was on the front line providing HIV testing and counseling. I've never given anyone a medical diagnosis, not alone provided them with information that could be perceived as life training. So I think I was humbled very quickly in my profession. In my professional career, and understanding that my responsibility is to help people understand their story, that I can have a skill set to help guide or facilitate, but really understand that the client is the expert of their experiences. And so, yes, I do have a certain skill set, and yes, you are the expert of your experiences, and together we can collaborate to get to some said space. I also now realize that that space, target, goal, destination, it's sometimes not what is most paramount. It is understanding the journey, understanding how you managed your own history, your own narratives, and how you get to said destination. And so I work under the belief that I'm always trying to put myself out of business. I want my clients to be empowered in a way where they understand how to develop their own framework, their own coping skills. I think it's working, but at the same time, we got a lot going on in the world right now, so I have to acknowledge that well. But I do say, my final comment is, I submit that I am not the expert of the client's experience, and I hope that allows someone else to maybe be free from the attachment, because it is an attachment. The belief that I have to know it all, and that means I'm the expert. No, you showing up with kindness and compassionate, that's what allows you to be in that space. Okay, I'm gonna stop now.
I really like that. I think that's really important, to not be attached to the answer, not be attached to the whatever it might be, you know, because if we get attached, then we have an expectation, then we have a condition, and that's not our job. You know, it's not my job as a therapist at all. But I wanted to go to your question, Yuvon, and I don't remember exactly what it was. I got really wrapped into John's thing there. I really liked what you were saying. But do you remember what your question was?
Yes, it was more so specific to kind of that burden of your patients feeling like they have to teach you,
Right,
and how
right.
to kind of overcome some of that.
Thank you. I needed that little tickler. I'm still about attachment to the goal. One of the big complaints that I hear in general when I'm talking to my colleagues about these issues is that a lot of times our patients who are in the LGBT community are a little weary of having to continually educate all of their providers, medical and psych, all of us and all of them. You know, they are tired of that. I can ask them questions about their personal lived experience about a certain thing, but I don't need to ask them to educate me about the whole culture of LGBTQ and the language and the terms. There is Dr. Google, and you can find damn near, excuse my language, anything you want. And I think that we should take it upon ourselves to educate ourselves and not expect our clients to educate us. Tell us about their personal things that have to do with that. Absolutely. Ask plenty of questions so you can really understand their story. And as Jon said, go on that journey with them, but don't expect them to educate you. That's our job for ourselves, in my opinion. I'll stop.
Right. I was thinking there's you know, I work in the addictions field, and a lot of times I will hear someone say to me, well, are you in recovery? And I'll say, well, why do you ask? And they'll say, well, if you're not in recovery, then you can't help me. And, you know, you know, their journey is not our journey. And I lost my train of thought again. This is a great question. Say it again, Yuvon. I'm sorry. I had a good point.
Yes, we were still talking about the kind of being in that situation where your patient is having to teach you.
That's right. And but we do have a responsibility to go to trainings, and we have a responsibility to become informed with, you know, the fundamentals of if we're working with domestic violence, if we're working with LGBT, if we're working with addictions, we need to know something. We do, and that's part of our professional journey. But once we have that foundation, then we can listen properly, we can listen actively, and we can really help the resident, client, patient tell their story. And that's our job, is to provide that safe space so they can explore their issues. If it's their sexuality, help them with that. If it's depression, sort of help them. But we have an obligation to take trainings and to do ongoing continuing education. And this is a part of that. Like, whoever is on this, you know, hopefully you're learning and sort of absorbing some different things from all of us, and that will help your journey with your clients.
I want to stir the pot a little bit. Can I stir the pot? So I accept, right? Yes, we should be in trainings, and we do have a responsibility to be on the edge of the curve, you know, ahead of the curve. When we see trends happening, go seek out that education. I do think, though, there is therapeutic value in the client being able to teach the therapist. And here's why I say that. Many clients have the perception that the therapist represents the power in the dynamic, in the relationship. And so being able to model and be in a space where they can speak to power or speak to authority, I think that's a powerful experience, because if I can do that with my therapist, then certainly I can do that with that member of my family who really doesn't agree with me. Or when I come home for holiday, they're very rude to me. I have experience articulating myself in such a way with my therapist, and I found out that that was okay. And so I think two things are kind of happening here. I can see this going both ways, but I think there's power in the client educating the provider. Okay, enough stirring. Let's see where this.
That wasn't a pot stirred. I agree with that. You know, we have our training, we have our education, but we have our ability to listen and help the clients with their journey. I think, and helping them practice, like like things that they talk about, the risks that they take with us, can definitely translate into family. I think that's a really good point, Jon. You know, that we're helping them practice, you know, communication that is going to be difficult maybe at the Thanksgiving dinner, you know, or with loved ones. So it's a really good point. No pot stirred from my perspective.
You took the words out of my mouth, Jenny. I was going to say, I don't think you stirred the pot. I think you just added a little sauce. And, you know, I think it's all about, you know, we need to educate ourselves, and we also need to let them tell us their part of educating us about their story, but not the general class.
Debbie, did you just say little sauce? I am loving you.
Little sauce.
Yes, thank you to our panelists. Wonderful conversation that we're having here. It sounds like, yes, there is some education that we need to make sure as providers that you all do get and you have that foundation, but opening up that conversation and allowing the patient to educate you isn't something that is, inherently wrong. You can kind of embrace that and utilize that to even help them kind of open some of those other conversations they may need to be having as well. Now, I will let our audience know that in regards to you all being able to educate yourself, we will be sending out a wide range of resources to all of you in addition to this program. So you will have kind of a nice little flow of a list of things that you and places that you can go to help educate yourself in regards to all of this as well. Now, one thing I did want to piggyback on, and we were talking about this as well, was kind of how times are changing. And so even in more specifically, the more recent times with us utilizing telemedicine more, I wanted to talk about like how some of the changing times might be affecting the way that you're interacting with your clients. And is it possibly the fact that maybe this telepsychiatry and telemedicine might be helping with some of that bias and that double stigma?
I want to say telemedicine rocks. I think I really like it. I think you have to get training in it though. Therapists need training in it. I joined the Telebehavioral Health Institute to learn more about the ethics of it, the confidentiality issues of it, our personal liability. So it's really important to do it properly. But once we have learned that, I find that we can reach people that we could never reach. Especially with COVID right now, we were quarantined for many weeks, and people are afraid to leave the house. And some people in rural areas, particularly rural areas for the LGBT community, there's not a lot of services that are available to them. And now we have telehealth, and insurance is covering it for those who have insurance and need to use that. It's really provided an opportunity to reach people that could never be reached before. And it is a challenge sometimes, because when you do telehealth, there's often a family that's on the other side of the door, and you have to be mindful that if you're working with somebody who is LGBT, they may not want their families to hear or know it, so they may be hesitant to talk about it. So there is a downside. There's something you have to be aware of. But overall, I think it's really opened doors for many people who can't travel, where the services aren't available. I think it's fantastic.
I'll add to that. I'm personally experiencing a great love-hate relationship with telepsych. For all the things that you said, I have a love relationship. I personally have, I'm more of a touchy-feely. I have a nice, really comfy office that really reflects kind of what how it's gonna be, in this space. It feels comfortable to me, is what that's about. My office is comfortable to me. So if it's comfortable to me, I'm probably going to be easier to be available. And that's just the truth, So I miss it for that reason. I keep this little giraffe here because I've got one just like it in my office. So when I get on my telepsych appointments each day, I start off and it's like the giraffe says hello, just because it's a little way to say we're still connected in the way that we were, because all of my patients saw me in person before, and I haven't been in my office since March 13th. So I do think for all those reasons you said, it's a wonderful thing. But I saw a patient today who I have not seen since the beginning of March, because he kept saying, I want to wait until you get back in the office. I've seen him since he's 10, he's 30 now. And he's somebody that I thought would have been the most okay with telepsych appointments. Big video gamer, pretty much just stays in online a lot. So I thought he would be totally down for it. He was the first one that said, can we put it off till you're back in your office? This was back in April, thinking I was gonna be in my office by May or June. We put off 3 appointments, and finally he said, do you do a 30-minute appointment? So I met him today, and I was able to say, so how was this for you? He goes, yeah, it was okay, I'll do it again. So my love-hate.
Okay, I think I'm going to come in from the angle of kindness and gratitude. I think it's important, at least in this space, as I have asked the participants to examine your own narrative and think about how parts of your story can act as barriers to treating this population that experience double stigma, right? Okay. And so in telling the truth, being kind to myself, I want to share that switching to telehealth was very challenging for me. But it had nothing to initially do with the technology. It was about my attachment to what I thought made me a good provider. And boy, did I believe that couch in the field of my office made, okay, I see you laughing at me, Debbie. I thought that couch and my lighting and my good snacks made me a great therapist, right? And so it was a moment where I had to examine my own story, my own narrative, and say, Jon, why are you freaking out right now? We believe in making anxiety our friend. Why are you firing off? And it was because I was feeding anxiety a narrative that said I wasn't good enough and I wasn't going to be effective. And I had to be kind to myself and say, okay, a part of that may be true, but guess what? I'm going to take a moment to plan. Well, first, accept the truth, right? And then I'm going to take a moment to plan. And that's when gratitude kicked in. And you're right, Cindy, that is exactly what happened. I became grateful for my increased ability to reach people who would have never walked through my doors before. I mean, parts of Georgia I didn't even know existed, and names of towns I didn't even know existed, right? And so that is what examining your own narrative can do without judgment. With kindness, it gives you a moment to step into grace, okay, missed that one, and then gratitude. And what I love about gratitude is it invites in its cousin, creativity. It does, because when you're thankful for the moment and you can stay present, it allows you to take inventory, to reassess and adjust and say, you know what, I know how I can make this better. Now, I don't have a giraffe, but now I think I'm going to be a little bit more creative. Go ahead, Debbie.
Yes, thank you all for sharing this, how there may be some positives and some negatives, and then also just kind of sitting in that space of your own personal issues that you may have had in regards to telepsychiatry. And the audience is also contributing, saying that they've seen some of those same things, those positives and those negatives, being able to be open to a wider range of clients in those like rural areas and things like that. And also feeling as though some of the younger population is more open to it because of their use of technology and kind of being more comfortable with that technology. So it's great to see that. Now, one thing that I did want to kind of piggyback on is even how you all are talking about like things you had in your office, and Jon, you have your snacks, but more specifically to what are some things that clinicians can do to be better allies to individuals that are LGBTQ?
So I'll start with that one, keeping an eye on the time. So I reached out to some of my colleagues and asked them that question before we got this panel together. And one of my colleagues who happens to be in the audience, Diana Vanderveer, she shared with me something that when she said it, I was like, oh my God, how did I not think of that? She said, I introduce myself with my pronouns when I have a new patient, you know? And I thought, oh my God, I changed it and put it on my paperwork years ago on my intake after I had somebody come at the university. We have something called T-START, which is a LGBT satellite office that does everything in the community. I mean, it provides all kinds of services. So I would have them come to my class, and that's where somebody mentioned, make sure you have that kind of thing on your intake paperwork. So I fixed it and I felt all good about myself. And then Diana said, well, I introduced myself that way. And I really felt like, well, how did I not think of that? You know, that just seems like so much common sense. And then as some of us were talking about it, we made sure that we put it on our email. And that was another one of those things. How did I not do that already? So I'm, as Jon said, thankful and grateful that I have colleagues like you guys to help me think of things that I know I don't have to bear the burden of knowing it all, even though sometimes I think I do. I know I don't really have to. So,
Debbie, I think that's a great idea. I'm going to take that one. That's a good idea. Just say she, her, really good idea. And so I appreciate that, because if we can do things like that to open the door, because people are understandably cautious. They don't know who we are. They should be, you know, we're professional therapists, but then you hear about, you know, conversion therapy and all these different things, and are you walking into a safe space, or you're not walking into a safe space, and sort of those kind of small gestures, I think are really important. I'm going to add that one. That was a good one. Thank you.
One thing that I took from conversation with you two is I hadn't thought about the symbolism, how important symbols play in our psyche and in our being. And so it's time to go art shopping, or I may be asking some of you all to help me with decorating, because that's not necessarily my thing. But I want to have some expertise from you all about what kind of small, gentle little things. And when I mean gentle, I mean it's not overt, but it's like, oh, wow, like I get that, thanks, right? I want my clients to have that feeling. And so as I've just expanded and went into a larger office, I think what can help me be a better ally is having more symbols in my office that shows that this is what this office is about, and holding that mantle. So in the spirit of allies, Mr. Ginny and Debbie, I will be tapping you all in the future to help me decorate my office under the umbrella of great symbolism and allies in the office.
Great, yes, and definitely. Thank you all for sharing some of those gentle things that you may be able to do as well. Some of the individuals from our audience have stated, you know, they have like rainbow lanyards in their facility that allows them to kind of note that that is something that they are open to and things like that. Also, one of the individuals that said, you know, yes, the pronouns are good, but we have to do more. So learning about some of your local national resources and making sure that you all kind of have those things and know what's really going on in your community as well. So thank you for sharing that. Now I am gonna keep an eye on our time. We will do our kind of brief wrap up here. So just each one of you on our panel, if you could give us just that one word takeaway, kind of overall, what you would like to make sure that the audience takes away from our conversation tonight.
Kindness.
Yesterday was welcome. Today is going to be curiosity.
With one word, I'm going to go with love again.
All right, kindness, curiosity, and love. So thank you all so much for a wonderful panel and discussion tonight. It has been great, and I will pass it over to you, Jon.
Yep, just really quickly, my one word is proud. That's the word I chose to describe how I feel tonight. I'm proud of the company, I'm proud of this panel, and I'm most proud of the 100 people, you guys who showed up, stopped your lives to come here to seek some answers, just little nuggets of knowledge to help understand my family, my LGBTQ friends and family. It means the world. In appreciation, I'm proud to announce that Myriad Neuroscience will be making a $500 donation to the following organization in our panelists' backyards. So for Debbie, Kentucky Fairness, they do great work passing anti-discrimination legislation and focusing on dismantling systemic racism in cities across the state. So far, 20 Kentucky cities and counties have passed the Fairness Ordinance. In Atlanta, so that was my old territory, this is my new territory, we are going to donate to Atlanta Lost and Found Youth, who provides shelter, food, and life stabilization services for homeless LGBTQ youth in Atlanta. And in New York, New Jersey, where I just moved from, we are donating to the Marsha P. Johnson Institute, which protects and defends the rights of a group of people who is constantly under assault, and that's Black trans people. Thanks again. Please fill out a brief survey that you will receive. Use the resource guide that they've worked so hard to put together, and we look forward to seeing you at our next GeneSight virtual event. Have a wonderful evening. Yeah, John, I started in Kentucky, gypsied my way to Brooklyn, gypsied my way to Atlanta. I grew up in Noonan. Yeah, so I'm here now, in Reynoldstown.
Right, Reynoldstown.
Yes.
Okay.
Near the Cabbage Factory. I didn't know what that factory was. I just knew it was in Cabbage Town, so I called it the Cabbage Factory.
By any chance, are we still live?
Yep.
Okay, great. Well, I will maintain.
We're amongst friends. Hey, Leslie.